Chapter 6 Macrocytic Anemias. Red blood cell indices: MCV greater than 100 fluid ounces, MCH normal, MCHC normal. Categories: Non-megaloblastic. Source of anemia is unrelated to a nutritional deficiency. Megaloblastic. Source of anemia is vitamin B12 or folic acid deficiency. DNA synthesis is impaired in these deficiencies. Non-megaloblastic. Compensatory bone marrow response to hemolytic anemia. Reticulocytosis. MCV usually only slightly elevated, less than 105 fluid ounces. Hypothyroidism. Chronic liver disease. Alcoholism, which has target or macrocytes, or hypochromic. Newborns. Differential diagnosis of macrocyte. Oval macrocytes are seen in folic acid deficiency, vitamin B12 deficiency, pernicious anemia. Round hypochromic macrocytes are seen in alcoholism, hypothyroidism, and liver disease. Blue-tinged macrocytes are seen in neonate response to anemic stress and response to anemic stress. Megaloblastic process. Folate, or vitamin B9, supports healthy cell division and promotes proper fetal growth. Legumes, eggs, leafy greens, beets, citrus, green vegetables, and liver. B12. Vitamin B12 is an essential nutrient that your body can't make on its own. You get it from meat, eggs, and cheese. DNA synthesis. Thymine triphosphate, or TTP. Folic acid is required. Vitamin B12 is a cofactor. TTP cannot be synthesized. It is replaced with DTP. Nuclear fragmentation, cell destruction, impaired cell division. Red blood cell precursors. Damaged DNA synthesis. Nucleated cells, both RBC and white blood cells. Changes to both red blood cell and white blood cell in bone marrow. Red blood cell precursors are larger. Nuclear structure is less condensed. Cytoplasm extremely basophilic. In megaloblastic precursors, there is asynchrony between the nucleus and the chromatin. The cytoplasm of most cells is extremely basophilic. Asynchronous cells. Nuclear age and cytoplasmic age do not correspond. Nuclear material and the cytoplasm, making it appear they are at different maturation stages. Ineffective erythropoiesis. Immature red blood cells in the bone marrow are prematurely destroyed before they reach the peripheral circulation. Intramedullary hemolysis. Megaloblastic precursor cells hemolyze before their maturation cycle is complete. Reticulocyte count is inappropriately low. Peripheral blood smear does not show polychromasia or nucleated red blood cells. Bilirubin and LDH are elevated in ineffective erythropoiesis. Pernicious anemia. Problems with intrinsic factor. Intrinsic factor is the most important ingredient in absorption of B12. Deficiency of vitamin B12 due to improper absorption. Antibodies to intrinsic factor are present in 56% of patients. 90% of patients showing parietal cell antibodies, suggestive of strong autoimmune component. B12 and folic acid deficiency. B12. Vegetarian diets, infants nursed by vegetarian mothers, and malabsorption. Folic acid. Dietary deficiency, alcoholism, and tropical sprue. Clinical features: middle age to older adults, high predilection for women, glossitis or sore or enlarged tongue, dyspepsia, diarrhea, neurologic involvement, numbness, difficulties in balance and walking, personality changes, mania, disorientation, depression, and impaired memory. Vitamin B12 deficiency, demyelinization of the peripheral nerves, spinal column, brain, spasticity, paranoia. Severe anemia decreases 7 to 8 grams per deciliter. Shortness of breath, lightheadedness, extreme weakness, pallor, jaundice, severe hemolysis, LDH increase. Hematologic features. CBC shows pancytopenia or low white blood cell count, low red blood cell count, and low platelet count. Macrocytosis, red blood cell inclusions, basophilic stippling, Howell Jolly bodies, low reticulocyte count, RDW increase, schistocytes, target cells, teardrop cells. And this is for vitamin B12 deficiency. The blood smear for vitamin B12 deficiency shows macrocytes, macroovulocytes, hypersegmented multilobed neutrophils, little poly in respect to anemia. Hypersegmented neutrophils show up early and survive through treatment. Laboratory diagnosis: pancytopenia, ineffective erythropoiesis, high MCV, declining HCT, highly elevated MCV of over 100 FL, low serum vitamin B12 and folic acid levels, elevated methylmalonic acid, or MMA, and homocysteine, increased intrinsic factor antibody. Treatment: B12 deficiency, orally, intramuscularly, subcutaneously. Lacking B12 daily oral dose of 1,000 micrograms. Pernicious anemia, 6,000 micrograms over a 6-day period to bring the patient back to normal stores. Maintenance given every 1 to 2 months. Folic acid deficiency, 1 to 5 milligrams per day for 2 to 3 weeks. Case study: a 50-year-old woman visited her physician because she had experienced weakness, fatigue, and shortness of breath for the past few months. Physician examination revealed a tall, slender woman with lemon yellow skin and a smooth red tongue. No hepatosplenomegaly was noted. She had experienced a loss of vibratory sense and had some problems with gait coordination. Her family history and her past medical history were unremarkable. The patient was not taking any medications. A complete blood count with white blood cell differential was ordered, and the results were as follows. White blood cell equals 7.4, with the normal range being 4.4 to 11. Red blood cell equaling 2.2, with the normal range being 4.12 to 5.1. Hemoglobin equals 8.5 grams per deciliter, with the normal range being 12.3 to 15.3. Hematocrit, 25%, with the normal range being 36 to 45. MCV equals 114, with the normal range being 87 to 98. MCHC equals 34%, with the normal range being 32 to 36. RDW equals 15.2%, with the normal range being 11.5 to 14.5. The platelet count equals 170, with the normal range being 150 to 400,000. The case study differential results were 67% segmented neutrophils, 5% hypersegmented, 25% lymphocytes, 5% monocytes, 3% eosinophils, red blood cell morphology, macrocytic with few macroovalocytes and few schistocytes, red blood cell inclusions, few holly-jolly bodies, reticulocytes 0.2%, with the normal range being 0.5 to 1.5%. Chemistry results. Total bilirubin 4 milligrams per deciliter, with the normal range being 0.2 to 1. Indirect bilirubin 2.9 milligrams per deciliter, with the normal range being 0.2 to 0.8. Serum LDH 720, with the normal range being 100 to 190. Serum iron 220, with the normal range being 50 to 170. TIBC 215, with the normal range being 250 to 450. B12 50, with the normal range being 100 to 700. Folate 200, with the normal range being 130 to 628. This is indicative of pernicious anemia because of the B12 or folate deficiency. Based on red blood cell indices MCV, MCHC, this anemia would be a macrocytic normochromic anemia. Increased MCV of 114 is the measure of size for the red blood cells, and it is high, so macrocytic. Normal MCHC of 34% is the measure of color of chromasia. It's normal, so normochromic. The decreased reticulocyte count represents ineffective erythropoiesis. Decreased reticulocyte count means there is a low number of young red blood cells, or reticulocytes, 18 to 20 years old, being pushed out of the marrow. But why a low number if there is anemia, and the bone marrow should be making more to compensate for the anemia, but it isn't, so we have ineffective erythropoiesis. The cause of this anemia is fragile red cells that have a shortened lifespan and are prematurely destroyed in the bone marrow and the peripheral blood, leading to anemia. The test used to evaluate B12 malabsorption is the MMA test. Chapter 6. The Macrocytic Anemias, from the book. Word key: achlorhydria, lack of hydrochloric acid in gastric contents. Intramedullary hemolysis, premature hemolysis of red blood cell precursors in the bone marrow. Paranoia, mental condition characterized by systematic delusions. Paresthesias, abnormal tingling or prickling sensation. Spasticity, involuntary muscular contractions. Macrocytic anemias and the megaloblastic process. The macrocytic anemias are a morphologic classification of anemias having mean corpuscular volume, or MCV, greater than 100. Elevated mean corpuscular hemoglobin, or MCH, and mean corpuscular hemoglobin content, MCHC, within normal range. Thus, these anemias are termed macrocytic and normochromic. Broadly defined, the macrocytic anemias are divided into two categories: non-megaloblastic and megaloblastic processes. The macrocytic anemia is non-megaloblastic if the source of the anemia is unrelated to a nutritional deficiency. If the source of the anemia is vitamin B12 or folic acid deficiency, the anemia is termed megaloblastic. DNA synthesis is impaired when there is a deficiency of vitamin B12 or folic acid deficiency. This is a serious condition and affects all readily dividing cells, skin cells, hematopoietic cells, and epithelial cells. The effects on the bone marrow and the patient's quality of life are dramatic and substantive. DNA synthesis depends on a key structure, thymidine triphosphate, or TTP. This structure cannot be formed unless it receives a methyl group from methyl tetrahydrofolate, or folic acid. Vitamin B12 is the cofactor responsible for transferring the methyl group to methyl tetrahydrofolate. Therefore, sufficient quantities of vitamin B12 and folic acid are key to the formation of TTP. If TTP cannot be synthesized, it is replaced by deoxyuridine triphosphate, DTP, which leads to nuclear fragmentation, cell destruction, and impaired cell division. For this reason, vitamin B12 and folic acid are essential elements in the DNA pathway. Red blood cell precursors in megaloblastic anemia. Because megaloblastic processes damage DNA synthesis, nucleated cells, including both immature red blood cells and white blood cells, are affected to the highest degree. There are multiple changes to white blood cells and red blood cells in the bone marrow structure that should be recognized and appreciated. The megaloblastic red blood cell precursors are larger than normal. The nuclear structure is less condensed, and the cytoplasm is extremely basophilic, or much bluer. There is asynchrony between the nuclear material and the cytoplasm, making it appear that they are different maturation stages. A careful comparison of the nuclear and cytoplasmic material in megaloblastic precursor cells versus normoblastic precursor cells helps differentiate cells. When a cell stage is asynchronous, the nuclear age and the cytoplasmic age do not correspond. The normal red blood cell series is programmed for two specific functions: hemoglobin synthesis and nuclear expulsion. For the nucleus to be expelled, certain changes must occur in the size of the nucleus and the consistency of the nucleus structure. The chromatin that begins as fine, reticular, and smooth must take on a different texture and conformation before it is expelled from the orthochromic normoblast. In megaloblastic erythropoiesis, the texture and condensation of the nuclear material are disrupted. Megaloblastic chromatin in the megaloblastic pronormoblast and megaloblastic basophilic normoblast is open-weaved, with a clock face arrangement of chromatin. This is easily imagined if you look closely at the chromatin pattern. The nuclear, or chromatin, material is fragile and lacks the composition and condensation of a nucleus ready to be delivered from the cell. Likewise, the cytoplasmic material in the early megaloblastic precursors is extremely basophilic, much bluer than normal precursors. You may have a difficult time observing the difference between normal red blood cell precursors and megaloblastic precursors. Careful study of the nucleus to the cytoplasm, or NC ratio, cell size, nuclear material, and cytoplasm color in each stage of each cell can help differentiate one from the other. Ineffective erythropoiesis in megaloblastic anemia. Erythropoiesis in the megaloblastic processes is ineffective because the immature red blood cells in the bone marrow are prematurely destroyed before they reach the peripheral circulation. This is in contrast to effective erythropoiesis, where young red blood cells are extruded into the peripheral circulation in response to anemic stress and observed on peripheral smear as polychromatic cells. The myeloid to erythroid, or M to E ratio, is 1:1 or 1:3, reflecting erythroid hyperplasia that you would see in the bone marrow responding to anemia. Megaloblastic precursor cells, especially at the polychromatophilic and basophilic states, hemolyze before their maturation cycle is complete. This development is termed intramedullary hemolysis. Orthochromic normoblasts, or reticulocytes, or both, do not have the opportunity to be delivered from the bone marrow as they normally would in response to anemic stress. Consequently, the reticulocyte count is inappropriately low. The peripheral smear does not show polychromasia or nucleated red blood cells, and bilirubin and lactate dehydrogenase, or LDH, are elevated. If erythropoiesis was effective and the bone marrow was responding to anemic stress, the peripheral smear would show evidence of a regenerative marrow process. Polychromasia and the presence of nucleated red blood cells would be self-evident. Consequences of ineffective erythropoiesis: bone marrow destruction of erythroid precursors, lack of regeneration of bone marrow elements during anemic stress, lack of nucleated red blood cells in peripheral smear, lack of polychromasia in peripheral smear, reticulocytopenia, intramedullary hemolysis, increased bilirubin and LDH, decreased haptoglobin. Expected effective bone marrow response to anemic stress. Production of red blood cell precursor cells is accelerated. M to E ratio is adjusted to reflect erythroid hyperplasia. Precursor cells, orthochromic normoblasts, are prematurely released from the bone marrow. Reticulocytes are prematurely released from the bone marrow. Polychromasia is seen in the peripheral smear. Nucleated red blood cells are present in the peripheral smear. If the reticulocyte count is high, a slight macrocytosis might develop. Pernicious anemia as a subset of megaloblastic anemias. Intrinsic factor is the most important ingredient to the absorption of vitamin B12 and subsequent delivery of vitamin B12 to the circulation. When problems with intrinsic factor develop, the condition is called pernicious anemia, a deficiency of vitamin B12 that is due to improper absorption. Several factors may account for the lack of intrinsic factor in the stomach, including physical factors such as partial or whole gastrectomy or genetic and immune factors. Whatever the cause, either intrinsic factor is not being secreted or it is blocked or neutralized in some way. Atrophic gastritis may occur in which gastric secretions are diminished and intrinsic factor fails to be secreted. The reason for this failure remains unclear, but age may play a role. Immune factors may arise that cause production of autoantibodies against intrinsic factor, thyroid tissue, and parietal cells, all of which decrease the production of intrinsic factor. Antibodies to intrinsic factor are present in 56% of patients with pernicious anemia, with 90% of patients showing parietal cell antibodies, suggesting a strong autoimmune component to this disorder. Additionally, pernicious anemia occurs more frequently in individuals with diabetes, thyroid conditions, and other autoimmune processes. Pernicious anemia may occur genetically as an autosomal recessive trait, often manifesting in children before the age of 2 years. Cubalin, a receptor for vitamin B12 and intrinsic factor, has been identified since 1998, but its role in juvenile-onset pernicious anemia remains unclear. Adult forms of congenital pernicious anemia occur and are associated with achlorhydria or malabsorption in relatives. Pernicious anemia is more common in individuals of Irish and Scandinavian ancestry. Patients with pernicious anemia experience all the symptoms of megaloblastic anemia, but they have a higher tendency for neurologic involvement, including neurologic manifestations and degeneration of peripheral nerves and the spinal column. Neurologic manifestations may be slow to develop, but include a vast array of symptoms. Patients may experience paresthesis in the limbs, an abnormal or clumsy walking pattern, or stiffness in the limbs. Treatment usually reverses these symptoms. Sources of B12 and folic acid. Vitamin B12 is found in meat, liver, kidney, oysters, clams, and fish, eggs, cheese, and other dairy products. Folic acid is found in green leafy vegetables, broccoli, fruit, whole grains, and dairy products. Conditions that may lead to vitamin B12 deficiency: chronic alcoholism, older age, vegetarianism, post-gastrectomy, achlorhydria, Diphyllobothrium latum, Helicobacter pylori, use of proton pump inhibitors, and malabsorption syndromes. Vitamin B12 and folic acid deficiency. Dietary deficiencies are rarely the cause of vitamin B12 deficiency except in individuals who consume a strictly vegetarian diet or infants nursed by vegetarian mothers who do not supplement their diets. Current research has indicated other potential sources of vitamin B12 deficiency, such as malabsorption syndromes, including cobalamin or intestinal malabsorption. Helicobacter pylori infections and long-term use of antacids may also contribute to severe food malabsorption, which will lead to poor vitamin B12 absorption patterns. Lack of intrinsic factor may occur after full or partial gastrectomy, and the parietal cells that secrete intrinsic factor would invariably be affected, thereby affecting B12 absorption. Recently, researchers have identified food-bound cobalamin malabsorption as one of the leading causes of B12 deficiency. Dietary deficiency is a serious consideration in folic acid deficiency and may occur in pregnancy or infancy because of increased requirement, or in elderly or alcoholic persons because of lack of availability. Folic acid is depleted from body stores within 3 to 6 months, and folic acid deficiency is one of the most common vitamin deficiencies in the U.S. in vulnerable populations. Tropical sprue is one of the most common malabsorption syndromes contributing to folic acid deficiency. It may also be expected in individuals taking methotrexate or other chemotherapy drugs because many of these directly affect the quality of DNA synthesis of normal and abnormal dividing cells in the absorption patterns. Clinical features of patients with megaloblastic anemia. Megaloblastic anemia is usually a disease of middle-aged and older adults with a high predilection for women. More than 20% of elderly individuals may have mild or moderate vitamin B12 deficiency, and these patients often go unrecognized because their symptoms are expressed with other disorders commonly in elderly patients. Expanding the definition of individuals who should be tested would potentially improve the diagnosis of megaloblastic anemia. Patients may experience glossitis, which is sore or enlarged tongue, dyspepsia, or diarrhea. Evidence of neurologic involvement may be seen, with patients experiencing numbness, paresthesis, and difficulties in balance and walking. Personality changes that may be observed include mania, disorientation, depression, and impaired memory. Vitamin B12 deficiency causes a demyelinization of the peripheral nerves, the spinal column, and the brain, which can cause many more severe neurologic symptoms, such as spasticity or paranoia. Severe anemia, in which the hemoglobin decreases to 7 to 8 grams per deciliter, is accompanied by symptoms of anemia, such as shortness of breath, lightheadedness, extreme weakness, and pallor. Jaundice may be seen as bilirubin accumulates because the average red blood cell lifespan in megaloblastic anemia is 75 days, a little more than one-half of the average red blood cell lifespan of 120 days. Hemolysis is severe and LDH levels increased. Hematologic features of megaloblastic anemias. The megaloblastic anemia shows striking similarities in clinical and hematologic presentations. The CBC shows pancytopenia, or low white blood cell count, low red blood cell count, and low platelet count, owing to ineffective hematopoiesis from lack of DNA synthesis, although the platelet count may be only borderline low. Pancytopenia in the CBC combined with macrocytosis should raise the index of suspicion toward a megaloblastic process because few other conditions show this pattern, such as aplastic anemia and hypersplenism. Red blood cell inclusions, such as basophilic stippling and Howell jelly bodies, may be observed. Howell jelly bodies formed from megaloblastic erythropoiesis are larger and more fragmented than normal Howell jelly bodies. There is a low reticulocyte count of less than 1%, and the red blood cell distribution width, or RDW, is increased, owing to schistocytes, targets, and teardrop cells. The blood smear in megaloblastic anemia is extremely relevant in the diagnosis and shows macrocytes, macroovulocytes, hypersegmented multilobe neutrophils, and little polychromasia with respect to anemia. The presence of hypersegmented neutrophils, a lobe count of more than 5 lobes, in combination with macrocytic anemia, is a morphologic marker for megaloblastic anemias. This qualitative blood cell abnormality appears early in the disease and survives through treatment. It is usually the last morphology to disappear. MCV initially is extremely high and may be 100 to 140. Elevated MCV occurs in chemotherapy, thyroid conditions, newborns, and chronic liver disease, and when the bone marrow is effectively responding to anemia. However, the MCV in these conditions is only slightly elevated, and these conditions are often seen in hematology. A bone marrow examination is not necessary for the diagnostic of megaloblastic anemia because the diagnosis of this disorder can be adequately made without this time-consuming, costly, and invasive procedure. Laboratory diagnosis of megaloblastic anemias. From the laboratory perspective, several important factors mark a patient as potentially megaloblastic, including pancytopenia, ineffective erythropoiesis, and high MCV. Pancytopenia, or low white blood cells and red blood cells and platelets, is not often seen in hematology and immediately causes suspicion of the likely cause. Likewise, ineffective erythropoiesis in the face of a declining hematocrit is an inappropriate bone marrow response because in most cases the bone marrow responds to anemia by delivering nucleated red blood cells prematurely, marked polychromasia, and elevated reticulocyte count. Laboratorians expect to see this on the peripheral smear of a severely anemic patient. Lastly, the highly elevated MCV, usually greater than 110, leads the clinical suspicion in the direction of a megaloblastic process. So when a peripheral smear is observed with severe anemia, few white blood cells and platelets, lack of polychromasia, and many macrocytes, a megaloblastic condition should be highly suspected. The differential diagnosis of these disorders depends on a sophisticated battery of laboratory tests that can help determine if the patient is lacking vitamin B12, folic acid, or intrinsic factor. Serum methylmalonic acid and homocysteine. When vitamin B12 is deficient, the metabolites methylmalonic acid, or MMA, and homocysteine are elevated and can be measured using a reference laboratory technique. MMA and serum homocysteine are valuable markers of even mild vitamin B12 deficiency and serve as important diagnostic indicators. When evaluated together, MMA and homocysteine can differentiate vitamin B12 from folate deficiency. Intrinsic factor and parietal cell antibodies. Parietal cell antibodies are seen in 90% of individuals at the time of initial diagnosis. The presence of these antibodies is not specific for a diagnosis of pernicious anemia. However, because parietal cell antibodies are seen in some individuals with endocrine disorders, intrinsic factor antibody evaluations are cost-effective, reliable, and highly specific for a diagnosis of pernicious anemia. There are two classifications of intrinsic antibody: blocking antibodies and binding antibodies. Blocking antibodies inhibit the binding of vitamin B12 to intrinsic factor, whereas binding antibodies prevent the attachment of the intrinsic factor vitamin B12 complex to receptors in the small intestine. Radioimmunoassay testing can delineate the nature of intrinsic factor antibody. Macrocytic anemias that are not megaloblastic. When macrocytes appear in the peripheral smear, it is important to observe them carefully for shape, color, or hypochromia, because these morphologic cues can aid in determining if the macrocytosis is megaloblastic or non-megaloblastic. Megaloblastic macrocytes are large and oval with a thicker exterior membrane and lacking hypochromasia. Macrocytes in the peripheral smear that lack any of these characteristics are usually not of megaloblastic origin. Several conditions can contribute to a macrocytic blood picture without a deficiency in vitamin B12 and folic acid. The most frequently seen conditions are a compensatory bone marrow response to hemolytic anemia, in which case a reticulocytosis can be seen. Because reticulocytes are polychromatophilic macrocytes, and because reticulocytes are prematurely delivered from the bone marrow in response to hemolysis, it is easy to understand how a macrocytic blood picture would develop. In these cases, MCV is usually only slightly elevated, up to 105. Macrocytosis may also be seen in conditions such as hypothyroidism, chronic liver disease, alcoholism, chemotherapy treatment, or a myelodysplastic disorder. In patients with chronic liver disease and alcoholism, the macrocytes are often targeted or hypochromatic. Additionally, macrocytic blood picture is noted in newborns because their bone marrow is immature and rapidly delivering nucleated cells and reticulocytes. Condensed case. A 73-year-old woman has a long-standing anemia. She had always been a poor eater. Peripheral smears have consistently shown hypochromia with target and many Howell-Jolly bodies. She has no surgical history, and she shows no blood loss through either the gastrointestinal or the genitourinary tract. Her laboratory results are white blood cells 2.7 times 10 to the 9th, red blood cells 2.25 times 10 to the 12th, hemoglobin 7.8 grams per deciliter, hematocrit 25%, MCV 111. Based on these findings, what is your initial clinical impression? This patient most likely has a megaloblastic anemia. Her age, dietary habits, and CPC support that impression. With her dietary history, she may have initially had an iron deficiency condition, and her peripheral smear results seem to verify that. It seems as if her condition has shifted toward a vitamin B12 or folic acid deficiency, however. Serum vitamin B12 and a folic acid assay, a methylmalonic acid, should be ordered. The summary points of this chapter are: macrocytic anemias have MCV of greater than 100 and normal MCHC. Megaloblastic anemias are macrocytic anemias in which vitamin B12 or folic acid or both are deficient. Not all macrocytic anemias are megaloblastic. Vitamin B12 and folic acid deficiencies lead to impaired DNA synthesis. The bone marrow in megaloblastic anemias is hypercellular, with the red blood cell precursors showing distinct chromatin and cytoplasmic changes. Megaloblastic anemias show ineffective erythropoiesis in the bone marrow, premature destruction of red blood cell precursors before delivery into the circulation. The peripheral smear in megaloblastic anemia shows macrocytes, oval macrocytes, and hypersegmented neutrophils. Pancytopenia and reticulocytopenia are prominent features of the megaloblastic processes. Patients with megaloblastic anemia may exhibit symptoms of anemia and neurologic symptoms, gastrointestinal symptoms, and psychological symptoms. Many elderly individuals are not diagnosed with vitamin B12 deficiency because their symptoms are assumed to be related to other illnesses. Intrinsic factor, which is secreted by the parietal cells of the stomach, is necessary for vitamin B12 absorption. Intrinsic factor deficiency can lead to pernicious anemia, a subset of megaloblastic anemia. Intrinsic factor deficiency may develop because intrinsic factor is not being secreted or because it's being blocked or neutralized. Of individuals experiencing pernicious anemia, 90% have parietal cell antibodies. Folic acid deficiency is the most common vitamin deficiency in the U.S. Serum vitamin B12, folic acid, and red blood cell folate can be determined by radioimmunoassay. Individuals with vitamin B12 deficiency require lifelong therapy. Folic acid deficiency requires short-term therapy. Serum methylmalonic acid and homocysteine are sensitive indicator tests of mild vitamin B12 deficiency. There are causes of a macrocytic anemia other than megaloblastic processes. Macrocytes may be seen in reticulocytosis, alcoholism, or liver disease. Case study. Mrs. C, a 79-year-old woman, presented to the emergency department barely able to walk. She said that she had gotten progressively weaker in the past couple of weeks and that she had noticed that her appetite was failing. She'd seen some yellow color to her eyes and skin, and that worried her. She had no desire to eat, but she did crave ice. She was thin, emaciated, and pale. She had difficulty walking and seemed generally confused. CBC and peripheral smear were ordered with more tests pending the initial results. Initial results were white blood cell 4.5 times 10 to the 6th, red blood cell 2.12 times 10 to the 9th, hemoglobin 7.5 grams per deciliter, hematocrit 22%, MCV 103, MCH 35.3, MCHC 34.9, platelets 105 times 10 to the 6th. The peripheral smear showed a mixture of microcytes and macrocytes, with target cells, schistocytes, few oval microcytes, rare hypersegmented neutrophils, and occasional hypochromic macrocytes. Because of the mixed blood picture, an iron profile was ordered, as well as serum folate and serum vitamin B12. This case study presents a confusing morphologic picture because no one red blood cell morphology leads to any single clinical condition. The follow-up blood work showed serum iron of 25 micrograms per deciliter. The reference range is 40 to 150. Total iron binding capacity of 500, with the reference range being 200 to 400. Red blood cell folate of 100, with the reference range being 130 to 268, and serum vitamin B12 of 200, with the reference range being 100 to 700. Clearly, multiple nutritional deficiencies are present. The patient is in a vulnerable age range that is prone to poor dietary habits and non-compliance to health or food suggestions. As can be seen from her lab values, she is deficient in iron and folic acid. Folic acid deficiency is one of the most common vitamin deficiencies in the U.S. and is easy to develop because folic acid stores are moderate and the folic acid daily requirement is high. Add this to her iron deficiency and you have a set of symptoms and a blood smear picture that represents a mixture of morphologies. She clearly showed a pancytopenia, but she did not show blatantly elevated MCV. Her elevated MCH could have been a clue to the megaloblastic process because MCV and MCH are usually elevated in the megaloblastic anemias. Her peripheral smear shows microcytes and macrocytes with a few target cells and an occasional hypersegmented neutrophil. She was immediately started on oral iron and oral folic acid supplementation, and her physical symptoms began to diminish. When a patient presents with a macrocytic blood picture, there are several clinical possibilities to consider. The most obvious reason for increased MCV is a patient with a megaloblastic process. Supporting lab data for this possibility would include a pancytopenia, a reticulocytopenia, increased LDH, and a peripheral smear with macroovulocytes, hypersegmented neutrophils, and other poikilocytes. Follow-up testing should initially include an assessment of vitamin B12 and folic acid levels and testing for intrinsic factor antibodies. Chapter 6 Review Questions. Number 1. Asynchrony in the red blood cell precursors is the most prominent bone marrow change in the megaloblastic anemias. Number 2. Oval macrocytes and hypersegmented neutrophils are the morphologic changes in the peripheral smear that are markers for megaloblastic anemias. 3. Folic acid deficiency is the most common vitamin deficiency in the U.S. 4. Difficulty in walking and mental confusion is particular to patients with megaloblastic anemias. 5. Intrinsic factor is necessary for B12 absorption. 6. Methylmalonic acid, or MMA, is the laboratory test indicative of vitamin B12 deficiency. 7. Lack of DNA synthesis describes the pathophysiology of the megaloblastic anemias. 8. Asynchrony is the morphologic feature that is classic in megaloblastic red blood cell precursors. 9. Thyroid conditions are megaloblastic. Examples of non-megaloblastic would be chemotherapy, post-splenectomy, and sideroblastic anemia. 10. Ineffective erythropoiesis is defined as premature destruction of red blood cell precursors.